This figure demonstrates the progression from normal to a diagnosis of prediabetes and from prediabetes to a diagnosis of diabetes. So you can see how the A1C just goes up. So anything under 5.7 for an A1C is considered normal. 5.7 to 6.4 is considered pre-diabetic, and anything above 6.5 is considered diabetes. And then the same for the FPG and the OGTT. So these numbers, normal, pre-diabetes, and then a diagnosis of diabetes. Prediabetes and diabetes can be identified using any one of the three tests. So they can use the glycosylated hemoglobin A1C, fasting plasma glucose, that's the FPG, fasting plasma glucose, or oral glucose tolerance, OGTT. These tests have distinct diagnostic thresholds for the diagnosis. So when I was pregnant, for example, I did the fasting glucose, fasting plasma glucose, and I've never had any prediabetes or anything like that. I tend to be hypoglycemic very easily. I can get hypoglycemic very easily, and so, but I got my number was like 140 something, and so they had me do it again, and it was the most horrible thing ever, because you're starving to death, and then they load you up with glucose, like an insane amount of glucose, and you feel shaky and nauseous, and it's awful. And the second test, I was normal, and so I don't know if it was just a false positive, but it was not fun. I will just share that little tidbit. But these are the distinct levels that they use to decide if you're in the normal range, pre-diabetic, or diabetic. Okay, so insulin is an anabolic hormone that stimulates entry of glucose into the cells and enhances fat storage. So if we didn't have insulin, then glucose would just remain in the bloodstream, and it wouldn't be available to help the glucose get into our cells and be used to produce energy and to fuel our bodies. So we would just have this buildup of glucose in our bloodstream. Oh, I did. Addition 4, sorry, it took me a second to know what I did. So addition 4, I wanted you to review box 44-3 and 44-4. And then for addition 5, it's box 49.3 and box 49.4. There's some good information there for you to review. In type 1 diabetes, the predominant problem is impaired insulin production. We kind of talked about this a little bit, just to review. So sometimes they're just not making any or very little insulin. In type 2 diabetes, the predominant problem is the inability to use the insulin produced by the body. So the body's making it, the cells just can't utilize it. However, a considerable overlap exists with regard to the clinical features of the two forms of diabetes. So we have the cardinal signs of diabetes, which are polydipsia, polyuria, polyphagia, and then unexplained weight loss and weakness. So polydipsia is, polyuria is excessive urination, polyphagia is excessive hunger, and I think polydipsia is excessive thirst. And then, of course, unexplained weight loss and weakness. So a lot of these can overlap between type 1 and type 2 diabetes. Some of the other things to note would be that they always talk about a fruity or kind of a fruity acetone note to a patient's breath, and then dry skin, dry mucosa, frequent infections, gingival infections, and frequent urination. Chronic complications of diabetes. So we have the micro and the macrovascular diseases, diabetic retinopathy, potential for vision loss. So that would be the microvascular diseases. Neuropathy leading to renal failure. Again, everything having to do with the breakdown of the vascular system and different areas of the body. And then peripheral neuropathy would be foot ulcers, neuropathic joint disease, so having to do more with the periphery, so your hands and feet, that sort of thing. Autonomic neuropathy, gastrointestinal, genitourinary, cardiovascular, and sexual dysfunction. So autonomic would be different functions within the body. And then periodontal disease. Those are all chronic, those are seen with long-term chronic diabetes. Individuals with diabetes have an increased incidence of atherosclerotic, cardiovascular, peripheral vascular, and cerebrovascular disease. Hypertension, abnormalities in lipoprotein metabolism, and periodontal disease are found in people with diabetes as well. So a host of comorbidities can go along with diabetes. Generally, kidney and eye diseases predominate with type 1 diabetes, and atherosclerotic disease predominates with type 2 diabetes, and neuropathy can occur with both. So, reduced systemic inflammation seems to be an important determinant in the relationship. So if we can reduce overall inflammation in our patients, then they seem to be able to control their diabetes better. Inflammation is the factor common to both diabetes and periodontal disease. We know inflammation is kind of what kickstart periodontal disease. In fact, emerging evidence supports an increased risk for diabetes onset in patients with severe periodontitis. So they're always studying this. There's lots of studies, and it seems like one really affects the other. We call it a bidirectional relationship. Sorry, because when one is worse, the other one becomes worse, and vice versa. So if their periodontal disease is uncontrolled, oftentimes they have a harder time controlling their blood glucose. And if their blood glucose levels are not controlled well, oftentimes they have a hard time controlling the periodontal disease. So it's this bidirectional relationship. The prevalence and severity of periodontal disease increases with both type 1 and type 2. A1Cs greater than 8% have a greater incidence of periodontal complications. Glycemic control is an integral part of controlling periodontal disease. And hyperglycemia leads to an increase in pro-inflammatory cytokines, destroys connective tissue and bones. So hyperglycemia is not a healthy state to be in. Periodontal disease in the diabetic patient. So positive outcomes not always typical with scaling and root planing, debridement, and biofilm control in the diabetic patient. It really depends on systemically how well controlled they are. So we could go and do everything that we normally do with a patient and still not get the great results that we're looking or hoping to get. However, removal of hard and soft deposits are crucial in trying to maintain the disease. So we still have to go through these processes as long as they're in a safe window that we can treat them, because hopefully it will improve their situation. SRP is indicated for diabetic patients, and evidence supports antimicrobial treatment after SRP, which would be the 20 milligrams doxycycline twice daily. And that's a very low dose doxycycline, so it's actually there. I just watched a really interesting CE course on this. They don't even call it an antibacterial effect because it's such a low dose of doxycycline, but it has shown to make a huge difference in patients' results after SRP. Antibiotic premedication is not necessarily an automatic requirement. You talk to the physician or their primary care, and then it also has to do with just their overall systemic health. So often they don't necessarily need pre-med. Matter of fact, I would say most of the time they don't, unless there is something like a heart condition or something, or a valve condition. Use epinephrine sparingly because epinephrine does raise blood glucose levels. So medications, insulin may be injected subcutaneously with an insulin syringe or a pen-like device. Insulin pumps are widely used to deliver a programmed steady drip of insulin under the skin for 24 hours a day. Patients with type 1 diabetes often use a pump. The push of a button on the pump delivers kind of a bolus dose to respond to the number of carbohydrate grams consumed at a meal. So it's kind of like a smart device for their insulin. Table 59.3 in the 5th edition shows the types of insulin and their onset and duration. And then I think in the other slide I told you the other coordinating one for the 4th edition. Oral hypoglycemic agents are only used in the treatment of type 2. So type 1 diabetes, they don't take like a pill, like an oral pill. They just do the injection of insulin. Metformin therapy is started by a primary care provider or an endocrinologist at diagnosis of type 2 diabetes. Generally, oral hypoglycemic agents stimulate the pancreas to secrete more insulin and increase the body's response to the insulin. Slow glucose digestion or decreased glucose production by the liver. So those are the different mechanisms that an oral hypoglycemic agent may do. They may secrete more insulin, increase the body's response, slow the glucose digestion, or decrease glucose production by the liver. Many people with diabetes are also treated with anticoagulant, antiplatelet drugs, antihypertensive drugs, or lipid-lowering medications. So somebody with type 2 diabetes usually has other conditions with other medications that are kind of going along with it. And then I write, Lexicon is our friend because it is hard to memorize all of these medications, their oral manifestations, oral implications, and side effects. So Lexicon is really an invaluable resource. Infection of any type can cause a profound disturbance of glycemic control that potentially leads to ketoacidosis and diabetic coma. So when an infection is present, the counter-regulatory hormones secretion increases, thereby leading to hyperglycemia and increased ketogenesis. So when your body is fighting a chronic infection, there's kind of a cascade of chemical reactions that happen that therefore lead to hyperglycemia, which is just everything we don't want a diabetic to have to deal with. So in a sense, that is why it's so important for them to monitor infection in the body and systemically and reduce that. So only 37% of type 2 diabetes can attain an A1C of less than 7%. So a lot of times we'll see our patients that haven't been able to get their A1C under control because maybe they haven't been able to take the lifestyle steps that will help them, implementing some regular exercising, making sure that their diets are really keen to keeping their blood glucose at a stable level and things like that. So there's a lot of work that goes into having to maintain and becoming controlled, and we don't see that necessarily as often as we'd like. An infection can profoundly disturb glycemic control. Diabetes makes patients more susceptible to infection in general, like we said. The immune system is compromised, and then the sugars that are available make it difficult for the body. It kind of sets the stage for bacteria to grow, and so that again is yet another thing that a patient with diabetes has to work against. And then also with the damage to blood vessels and nerves, it doesn't let the white blood cells get to the parts of the body where it can fight the infection. And then the nerve damage, patients don't always know that they have a cut or an injury. And infections can get worse because of that. Infection is the most precipitating factor in severe ketoacidosis, we said that. And poor diabetic control may aggravate oral disease. That's that bidirectional relationship. Stress can contribute to hyperglycemia. So it's really important that we help our patients to have a comfortable, as relaxed experience as possible, because we don't want to add stress to that visit and to them, because that can also have a negative effect on their blood glucose levels. When obtaining a patient's health history, the dental hygienist questions the patient about the signs and symptoms of ketoacidosis to determine whether an undiagnosed diabetic condition is present. So assess the risk of undiagnosed diabetes, or if a patient is at high risk. So that's that going through the medical history and kind of having those red flags that kind of ping your interest and then make you ask more questions. CDC recommends that the dental office administers a chairside A1C or a blood glucose self-monitoring device. We have the glucose test, we don't have the A1C. In the aging population, traditional symptoms don't usually manifest, so things can look different at different stages of life. And then in the aging, clinical findings are related to chronic complications such as vascular disorders and neuropathies, neuropathic syndromes. So when the person is a known to have diabetes, the patient in the health history interview should address the following: the decision to continue the comprehensive assessment, consult with a physician, or defer treatment and refer the patient to a physician should be made on the basis of a patient's responses to questions during the health history and the pharmacological assessment. Consult with the physician. Basically, when you have a patient come into your chair and you determine that their blood glucose levels are too high, then that's when you decide to consult with a physician, defer treatment, or refer to the physician. So you may call the physician, ask questions, delay treatment, or you may refer them immediately to a physician. So these are kind of bullet points of during your health history interview. So what kind of diabetes do they have? Methods used to control the diabetes. What kind of medication are they using? Medication schedule and doses. Did they take their medication already, and how much do they take? And if they didn't take it, why? Because they forgot, or they normally take it at a different time. Date and results of their last A1C. You want to always have the most current one on record. Frequency of self-monitoring. How often do they check their blood glucose? Fasting blood glucose levels, if they know that, if they've had that recently. Results of self-monitoring. Trends, as well as those of the day of the appointment. It's good for them. If they know all this stuff and they answer fast, chances are they're probably well controlled, or they have been struggling to get well controlled. Blood glucose levels 2 hours after meals. I think this means blood glucose levels off 2 hours after the meal. I think there's a typo there. Date of the last hypoglycemia episode. So if they have had a medical emergency type situation, when did that happen last? When did their diabetes first get diagnosed? And then regularity of appointments with their physician. How often do they get see their doctor to see about, maintaining everything and get their tests. And then the 6 complications of diabetes. So that being the comorbidities that go along with it, the medical emergencies, the neuropathies, the infections, all of the major things that we have to think about when we consider our patients with diabetes. So levels of blood glucose for care planning. So like we said earlier, 80 to 120 is normal. If a patient is 70 or below, that is hypoglycemic. You can provide them with a little bit of a snack, a glass of orange juice, and usually that will bring them back up and they'll start feeling better. 70 to 79, monitor at least once during the dental hygiene appointment. If they're that low, check in with them. How are you feeling? Are you feeling dizzy? Are you feeling nauseous? Feeling cold, clammy, sweaty? 80 to 149 is considered okay. If you're dealing with a diabetic, you'd expect their blood glucose to be a little higher. 150 to 200 is in the higher range, and then 200 above is too high. Check with the physician, and then we defer treatment. And the little asterisk indicates that the dental hygienist care should not be provided. So if they're too low or they're too high, then that's when we don't provide dental hygiene care. And you may take their blood glucose. If they're 70 or low, give them some crackers, give them some orange juice, and then check it again in like 10-15 minutes, and you may be able to then provide treatment. When to refer to a physician. Refer the patient to a physician for diagnosis and treatment when the patient has the following. So the cardinal signs of diabetes, which we talked about in an earlier slide and is in box 59.3. Symptoms that suggest diabetes. Estimated fasting blood glucose is at or above 126. 2-hour post prandial blood glucose at or above 200. And long periods since patient was last seen by their physician. If they haven't seen a doctor at all in 5 to 10 years, you may just want to screen them anyways, and of course refer them to a physician. Diagnosed diabetes plus signs and symptoms of diabetes. Type 1 diabetes with extreme hyperglycemia and hypoglycemia and an infection anywhere in the body. Those are always times when you would refer them to a physician.